Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Justin Arner from Pittsburgh, United States. Dr. Arner is a double board certified orthopedic surgeon and sports medicine doctor at the University of Pittsburgh in Pennsylvania, United States. Dr. Arner completed specialized training with a fellowship in sports medicine and shoulder surgery at the Stedman Philippon Clinic in Vail, Colorado. He completed his orthopedic surgery residency at the University of Pittsburgh and graduated medical school from West Virginia University as a member of the Alpha Omega Alpha Honor Medical Society. As an avid researcher, Dr. Arner has published over 100 articles and 20 book chapters, as well as more than 100 national and international scientific presentations. Dr. Arner is monthly podcast host for the Arthroscopy Journal, which is the highest impact factor in orthopedic sports medicine. He is very active in journal reviewing for each of the highest impact journals in orthopedics. Additionally, Dr. Arner is extensively involved in multiple orthopedic societies as committee chair and member. If you've noticed, Dr. Arner has delivered a lecture on our channel before and has already reached a huge audience. And today is my great honor to bring back Dr. Justin Arner for this wonderful live program. Over to you, Justin.
Thank you, Professor. I'd like to applaud you on all your hard work with this. It's so impressive. You put in all this time and effort to educate people for just the good of the cause. So how many people are doing that in 2025? So it's an awesome thing you're doing. So thanks for having me back. I'm honored. And I wanted to talk about meniscus healing, which we all know is a big problem, and how to optimize that. And we certainly have a long way to go. I don't have any financial disclosures related to this topic. We're familiar with the anatomy. The medial meniscus and lateral meniscus are C and U shaped. The lateral meniscus is more mobile. It's this fibrocartilaginous structure, and it's important with load bearing. And we know meniscectomy, even if you take an inferior leaflet of the meniscus, can really decrease the contact area significantly. It's helpful in stability of the knee and lubrication and proprioceptive, and it's very contraproductive. Most of it's water. We know the different portions of the meniscus. Most of it's type 1 collagen. There's more type 2 centrally, and we know about the glycosaminoglycans, but blood supply is essential. In this classic photo showing the vascular zone, or the red zone laterally, and the peripheral rim, and how it's more avascular centrally. So central tears, which are a majority of tears or a significant number of tears, have the limited intrinsic ability to heal. The more peripheral ones have fibrocartilage healing techniques or type of healing. So we know meniscal preservation is absolutely essential. We've seen this time and again. So this study by Prof showed short and long-term less arthritis, improved patient-reported outcomes, but there is a higher reoperation rate than if you just remove the meniscus. Systematic review by Laprod's group showed improved patient-reported outcomes at minimum 2-year follow-up. And Dr. Rick Wright showed 24% failure, which I talk to my patients about, the literature shows, and complications of 5%. But it's complicated. You know, is it easier to just remove the meniscus? Yes. Are there less reoperations? Yes. Or less complications? Yes. But you know, at 10 years or longer, we still do have concerns here. So repair techniques, you know, the classic inside out, which, you know, I think is somewhat falling out of favor, but I still think is the gold standard, where you make an incision either medially or laterally behind the knee and put a spoon or some type of retractor back there and pass the sutures and then tie them over the capsule. Certainly there's much better technology with all inside devices and without assistance, and it's much help, and it's more technically, I think, less challenging, and time is a little bit quicker with those. So here's comparing the two techniques, inside out versus all inside, and basically the data show that there's no difference. So certainly this is a quicker technique, but I think sometimes it's better to get those balanced sutures that are smaller from the outside in, from the inside out, in my personal opinion. So failure rate up to 29% at 13 months for bucket handle tears, and higher failure rates the longer you look. And this study showed no difference between with and without ACL reconstruction by Rachel Frank from Colorado, and males had a higher rate of failure. So this is a systematic review looking at bucket handle tears, and you know, that's a high failure rate. Here's another study from the Moon Group, which is a big study, 646 patients, 16% failure rate. And they looked at the different types of ACL reconstructions and different types of meniscus. And it really medial failed more than lateral if people had poor or higher mark scores preoperatively, and allograft did not do as well as autograft. So interesting findings, but it's certainly a huge issue here. So how do we fix these or improve these meniscal healing rates? Well, there's three types of required factors, and just in general for healing, you need the correct cell type and the correct number of cells, and you have to be able to form a new matrix to allow this healing. And we have to have the biology on top of those cell types and the matrix. So we need signaling cells to differentiate cells and stimulate expression of that matrix. So people use fibrin clot, PRP, like the alpha granule to try to bring the cytokines. Are there scaffolds to try to get cells to heal to support new tissue formation? So you can see some examples and pictures here. And here are the biological targets: cell homing from the synovium and meniscus, like we talked about, alpha granules, to stimulate the intrameniscal cell proliferation and matrix production, to increase vascularity at the repair site, like we talked about, which is a big problem, and then remodel the repaired tissue. So you can see the homing mechanisms that I remember from medical school. You have the cell tethering, and the chemokines or cytokines activate. They get really tethered there with integrins, and then the cells can migrate, and the growth factors can do their job. But the management of the post-injury and post-surgical inflammatory process is really essential, and something that we see studies about, but I think is not on the top of our mind, unfortunately, with busy surgical practices. But optimizing that environment post-injury and post-surgery, I think, is something that's probably going to be more and more important over the years. So what factors do we need? We need fibrochondrocytes, and here are the ones that have a positive effect. So FGF, PDGF, TGF beta, insulin growth factor. These are the good ones. These are the ones that we want. So they help heal articular cartilage, wounds, and ligaments. So just in biological sense in general. And platelet-derived growth factor has 8 times the cell proliferation and 4 times the matrix production. So platelet-derived growth factor is really, I think, the most important one based on this data. And I know this picture in the bottom gives us a little bit of the willies with remembering medical school, but and we want to try to minimize the negative pro-inflammatory cytokines. So tumor necrosis factor alpha, insulin-like growth factor 1, those are the bad metalloproteases that are stimulated, and they decrease cell proliferation. So the goal is to obviously support the fibrochondrocytes with these positive growth factors like platelet-derived growth factor, and trying to minimize the negative pro-inflammatory cytokines. So, but how do we translate this into practice? It's difficult. It's easy to talk about all the great work that these basic scientists have used, but how do we do that clinically? So, clinical evaluation of all these factors is unfortunately pretty limited. There are a decent number of rabbit studies. Here are some from arthroscopy and JBJS. But here you can see an impregnated hydrogel was placed in rabbits, and that showed higher cell density and proliferation of cells, and VEGF, which we're familiar with, we know is essential for healing. There was a study from Sebastian Koff with 18 sheep that did not improve healing, unfortunately. But here again, to summarize, the positive and inhibitory cytokines and growth factors. So more in vitro and in vivo studies are growing and ongoing, but I think this is the key when we step back to really support these factors. So where are we clinically now? How can we improve the healing? So, most of us, or a lot of us, do this. You can do it mechanically to stimulate neovascularization and healing. So, a cheap and easy way is rasping the tissue, which, I tend to do in all my cases. Sometimes I wonder how much it's helping. Other times, you can see you can roughen that tissue that's starting to heal, and you can get some of that soft tissue off of it, and it does kind of refresh the border. Other times, I'm not so sure, but this really helps induce synovial ingrowth and cytokine expressions, like those ones we were just talking about. Proliferated nuclear or cell nuclear antigen is another one that it seems to help with. So trephination is another technique where you take something like a spinal needle and put little vascular channels. So I'll do this as well, but the concerns, especially with the trephination option, are you making all these holes in the meniscus that are then destabilizing the structure of the meniscus. So It's limited data, like I mentioned, is detrimental to the structure of the of the meniscus itself. Another cheap and easy way that a lot of us do and has been around for a long time are bone marrow venting of the notch, which I do either with a pick here or a Stedmanol. Shout out to my fellowship, Richard Stedman. So here's a study from Brian Cole's group in 2003 showing that improved healing, and that was in the arthroscopy journal. There was basically a study from Stedman where I was a fellow that showed basically it was just as helpful as if you did an ACL reconstruction. So, we know when we drill, or we think when we drill those tunnels, those bone marrow elements from the ACL go into the knee, and that really helps with meniscus healing. And marrow venting in this 2017 study from the Stedman Philippon Institute showed it was equivalent. And then in our RCT, it did show significant improvement in the rate of healing of the meniscus, and that was 100% versus 76%. So there's some promising literature here. It's easy to do, it's cheap, it's fast. So obviously, as orthopedic surgeons, we like that. Fibrin clot, which is something that in Pittsburgh, Chris Arner and Freddie Fu really were advocates for. Typically, I'm not doing this as often, and I worry that that fibrin clot, once it kind of goes away, how tight are the sutures, how robust is that repair? But certainly, it makes sense. It's cheap. Dr. Fu and Dr. Arner would always talk about having a glass beaker and a stir. It doesn't get more cost appropriate for cost than that. So basically, you're taking the blood and fibrin and platelets to make a scaffold for repair. And those have all the great elements from the blood, like PRP, which we'll talk about, alpha granules, and then there are dense granules with a lot of different cytokines that we talked about before. But a lot of this data, again, is preclinical studies. But there is a study from 1990 showing decreased failure rate of 8% versus 41% for fibrin clot. So, and again, it is, I think, technically somewhat challenging to put that clot in there and repair it how you want, but certainly is a good option. I'm using PRP in most of my and all of my meniscus repairs. Actually, there's some promising studies, but it's somewhat mixed here. Here's a study from the knee in 2009 that's evaluating the whole body of literature, that they're saying that they're promising studies, but there's a number of RCTs and tendon healing showing that it doesn't do much. And there's no RCTs looking at meniscus healing. So it's more anecdotal, theoretical case series. We know that the mechanism of action of PRP, platelet-derived growth factor, does induce fibrocartilage proliferation and new matrix formation, and it increases fibrocartilage related to mRNA, which again, as I mentioned, fibrocartilage is really the essential thing here. And there's a nice rabbit model from tissue engineering with PRP on a hydrogel, showing better histologic and mechanical properties. So what is PRP? We know the blood has red blood cells, white cells, and plasma. So the plasma is the non-cellular portion with the platelets and the growth factors. So, it's really hard to really get information from the literature. There's so many different PRP systems. Some are putting them in the refrigerator overnight. Some of them are adding additives to it. Some people are waiting an hour. Some people are injecting it right away. We don't know the patient's biological makeup. People that do a lot of PRP, you can just look at it and tell there's a difference in different people's PRP. But the American Red Cross says it's blood plasma with 2 times the platelets or more. And again, there's no consensus on the definition, the optimal amount of white blood cells or optimal amount of platelets. Maybe too many platelets is worse. A lot of times the white count being higher, we don't like for cartilage. We like more for tendon healing. And again, there's just so many systems and preparations. It's really almost impossible to compare the literature. So there's difference in cost as well, which is sometimes somewhat prohibitive. So we know that platelets or normal biological play a very significant biological role in healing because of these growth factors and proteins. So PRP typically 3 to 5 times is what a lot of us talk about, promote healing. Again, if it's way more than that, maybe it's actually inhibitory. And alpha granules, as I've mentioned a few times, really have the growth factors we want, like platelet-derived growth factor, VEGF, FGF2. So it works as chemotaxis, where it brings the cells there, helps with differentiation, improves blood flow to the area, and extracellular matrix formation. So it's really something that makes sense to us. So here are some clinical studies with PRP ranging from 2015 to 2019. So here's a nice study, a case control study with 17 PRP versus 17 controls with horizontal tears. And at 2 years, they found PRP had better patient-reported outcomes in MRI healing, so 75 versus 40%. And PRP versus the control for the inside-out repair, those were 2 studies, didn't show any difference in re-tear patient-reported outcomes. There's a bigger study with 550 patients with PRP versus meniscus repair with ACL reconstruction versus a control. And basically, it showed that it was equivalent if the ACL reconstruction was done. So at 3 years, PRP had a decreased rate of failure versus the control, 14.6 versus 17, which isn't a huge amount, but 550 patients, it's significant. And it was equivalent basically if the ACL reconstruction was done or if you injected PRP. So like I said, I do inject PRP in my patients. I think it depends on your system and something you should work with. And I know internationally, I'm sure it's different, but you can work with your system and have a way to build the use of the spinning, the folks that are obtaining it and eating the cost of the kit, maybe something that you can bundle with the surgery. So does PRP help the meniscus heal? Here's a nice comparative study from Eric McCarty, our upcoming AOSSM, our current AOSSM president, actually. So basically, that study and then Seth Sherman's study show that it does lower failure rates with meniscus repair. And these, again, are systematic reviews. But the PRP is somewhat controversial. This first study shows no difference, and the second study shows there is difference in the same journal. So interesting. It's so hard to kind of tease all this out. So here's an AJSM article, 2021 retrospective case control 162 controls versus 162 PRP, and PRP showed no improvement in outcomes if there was ACL done, but it did have higher rates of stiffness. So obviously, this gives us some pause. Walt Lowe is such a huge, high volume expert surgeon in Houston. So he showed a higher rate of postoperative stiffness if you did it with an ACL. It's a well done study, a case control study. So interesting, but not something that's changed my practice. So we don't really know, is it clear PRP is the answer? Not necessarily, but if it's possible and affordable and something you can do, I think there's a little downside. In the United States, at least, and everyone wants to ask about quote unquote stem cells, but with our FDA rules, we can't technically give quote unquote stem cells as we can't manipulate these cells out of the body. In Germany and other places that's allowed. So we're only able to quote minimally manipulate cells, so we can't grow them in the lab. So, MSCs in the States, at least from bone marrow aspirate, from the synovium and the adipose, those are kind of our options. And there's numerous preclinical studies. There's 13 studies when I recently looked, and 13 of them have MRI follow-up. Again, animal studies. So there's some rabbit studies showing the source of cells and trophic mediators of the repair, and that it's better than PRP and the control. And they think it's maybe due to the anti-inflammatory profile of meniscus healing. And it's different based on the source of healing. So in a swine model, it did help heal avascular tears, which is important. So these are promising preclinical studies. So I found 4 clinical studies, 2 case control, 2 case series, and 1 case report of quote unquote stem cells. So you can see one from 2023 here in arthroscopy, 17 patients, a minimum 1 year follow-up, and there was 0 reoperation rates, and everyone improved their MCID. And then there are other smaller studies with 5 patients with synovial MSCs that were injected 2 weeks after the repair. There's some rotator cuff studies with PRP and things looking at that as well. Interesting to inject them afterwards at the post surgical time frame, which is again probably more essential than we give it credit for. And those increased patient-reported outcomes. There was healing on MRI, and again, no revision at 2 years. So that's such a small number of patients, but an interesting option here. So there's another study with 5 patients with a collagen scaffold and bone marrow aspirate concentrate, and 2 of those 5 people had future meniscectomy. So that's again small study, a little bit concerning, that last one, but there's need for further research, and cost is an issue as well. So here's a more recent study from OJSM, and this looks at the impact of biologic augmentation on revision surgery. And this is 3,420 patients. It's a Pearl Diver database study, which has certainly large flaws in it, but it's big numbers, and they did not find any difference in revision rates with BMAC or PRP by themselves, but with an ACL, it did have a lower revision rate of surgery, 5.2 versus 7.9. Again, not a huge number, but it's, again, cost is an issue, and I think we need better data. So moving along after, the PRP, the MSCs, what are the sources, possible cell sources for tissue engineering? I think that's the next step, and certainly there are people a lot smarter than me that are working this out, and it's interesting and impressive, mostly preclinical studies. But meniscal cells, chondrocytes, mesenchymal stem cells from bone marrow, adipose, or synovium, as mentioned, but there's no comparative studies between these. And here are the different scaffold options, as I was starting to mention, from synthetic polymers to hydrogels, which I mentioned in some of the porcine models, to other matrix like collagen, and then decellularized extracellular matrix, tissue-derived materials. So this is an area outside of the orthopedic surgeon's expertise. There's great tissue engineering scientists out here that know much more about this than me, but again, there's promising results in a lot of preclinical animal studies. Here's one study that looked at 21 patients with collagen matrix wrapping. This is a recent study from 2024. It showed 9.5% failure rate at 33 months, and they had high satisfaction and high IKDC scores. So interestingly, you can see this picture up here where the labeled E. I don't know if you can see my pointer, but basically they're wrapping that collagen matrix around the meniscus and suturing it to try to give it some bulk, which we do in the rotator cuff with structural grafts and other places. So it makes sense to do that here, but there's no consensus on the right type of material. As I mentioned, all these different options, the right way to fix it. How can you biologically add something to these scaffolds? So certainly an area of the future, but something we still, as I keep mentioning, need, I think, a little more data with. So here's a study from the Knee Journal from the Ohio State group with Dave Flanagan. And basically, there's 19 studies, over 1,000 menisci, and a systematic review. So you can see 6 with fibrin clot, 5 with PRP, 3 with bone marrow stimulation, 2 with meniscal wrapping augmentation, which we just talked about, and 3 other options that were evaluated here. And basically, PRP and bone marrow stimulation decreases risk of failure, but didn't have any effect on functional outcomes. And then fibrin clot and meniscal trephination did not decrease failure. And the meniscal wrapping and scaffold augment, there are a few studies there, but those a few studies, which I did mention, one of them shows some interesting, possibly data and improvement here. But again, cost is an issue. I don't think insurance companies in the United States are going to be jumping to try to pay for a scaffold augmentation of a meniscus. And technically, that's demanding. As we get towards the end of our study, Johnny Heward, who really was very active in Pittsburgh here as a lead scientist when I was a resident, and now has transitioned to the Stedman Clinic, has been there for quite a few years when I was there as a fellow, has really pushed and very interestingly looked at repurposing medications. He's a smart guy that for the FDA in the United States, to get a new medication or new type of technique or something that's not approved is quite difficult. But if there's a medication like losartan that's already FDA approved for blood pressure, we could repurpose this as kind of an off-label option to improve healing. And I think it's pretty genius. So he's done a lot of research for this over the last decade, or probably a decade and a half, basically showing us, and others have shown, that losartan also inhibits TGF beta 1, which is an antifibrotic important thing in our body. So it exerts an effect in endothelial mesenchymal transition. So basically, it inhibits scar formation, which the fibrosis is helpful for repair, but overfibrosis or fibrosis without it being in check, such as cartilage repair, is worse. That a microfracture, we get scarred hyaline cartilage, but these rabbit model studies, which I've been lucky enough to be involved in, really showed that it can increase the endothelial cells and decrease the fibrocytes, and basically improve the quality of cartilage repair and make more hyaline-like cartilage with microfracture by decreasing this TGF-beta1. So interesting, and losartan improves the type of BMAC as well. So this first study looking at PRP and BMAC, if you added losartan to it, it made basically those more clinically useful because it decreased the TGF-beta1. So more clinical studies are being done by that group in Vail. So interesting possible option here that could improve the type of tissue that's healing the meniscus rather than just poor scar that possibly is at risk for shear failure. Could it have a better healing response? So here's other options for repurposing medications like anakinra and some of these other medications and cancer treatments. So there's a clinical trial with montelukast with ACL reconstruction and meniscal injury evaluating post-traumatic arthritis. And this Singulair is the brand name in the United States for asthma. Could it decrease inflammatory cell biomarkers? And simvastatin, and we've seen things like metformin and rotator cuff repairs be published recently that could those make better quality tissue? Very interesting options. And I think this is a way, at least in the United States, that we could possibly improve healing of different areas of the body by repurposing some of these medications. So you can see simvastatin in the rabbit model showed better collagen 1 and 2 and better stiff quality tissues. So there's no clinical studies. So in conclusion, there's a long way to go. This is a call to arms, as if you will, that we need more of these excellent, smart, basic scientists to push the envelope, and for us to work closely with them. And we know surgical techniques, I think, are better and more optimized, and the way we suture the meniscus and keeping the meniscus despite the high risks of requiring future surgery. But biological augmentation, like I keep mentioning, is much more important, I think, right now. Just like the rotator cuff, we know how to fix these. We have good suturing techniques. We have good options. But the biology, I think, is what's missing in both of those options, the meniscus and the rotator cuff. But it needs to basically be affordable, efficient, and with little futz factor. Like, if you have a large number of cases and you have a big case here, do you need to keep the case moving, and efficiency with anesthesia? And we know all those important efficiency things with surgery. I think those are what are really going to push this forward. So we need more preclinical data and clinical data. And I look forward to, in 30 years, I always think, what are we going to be thinking? What were we doing 30 years ago? But I think this is something that in the meniscus and rotator cuff, we're going to be far ahead of where we are now. So I appreciate the attention and the opportunity here. And hello from Pittsburgh. Thank you.
Thank you so much, Justin. Yeah.
Thank you.
Thank you so much, Justin, for this yet another wonderful presentation. You have covered the entire spectrum of meniscal healing.
I don't know. It's a long way to go still.
Yeah. So, Justin, a few questions. Now, there's been a trend to repair the meniscus, right? All over the world.
Right.
And given a bucket handle tear, whenever there's a bucket handle tear, the reoperations are quite significant, right? There's up to 20% reoperation. So do you think these materials, like what we mentioned, could help reduce those reoperation rates?
That's the goal and the hope. Obviously, anything we can do to decrease 20% is an unacceptably high rate of failure. So like I mentioned, PRP is something that I do. It's easy to do. It's easy to inject the knee. But I think these meniscal scaffolds are interesting. And if there's a way you could improve cellularity, it's just how to get your hospital or insurance company to pay for them is the issue. So we certainly need things that are going to improve this. I think 20% is unacceptable, and we need to keep pushing these basic science studies into clinical clinical realms, but obviously in a safe way. But yeah, for sure, I think there's a lot of promise here.
And what if we use BMAC instead of PRP? We have better mesenchymal stem cells, right?
Right. Yeah, so the data with that is quite limited, surprisingly. The BMAC makes a lot of sense. It's more invasive and expensive. So in the United States, it's harder to kind of get your hospital to eat that cost since it's not covered by insurance. But I know, in the military, and I'm not as familiar with the international realm, which, would be helpful if you could educate me and us. But um, I think something that a lot of these companies could probably um, minimize the cost somewhat. If you work with your health system, we do that on the hip a decent amount. With hip arthroscopy, people that have early arthritis, I think it does help the BMAC when you're doing a labral repair in the hip. So I think it makes a lot of sense. There's just few studies looking at that. I think just with cost, at least in the United States, but it'd be interesting to hear what your thoughts are about that as well.
Yeah, here it wouldn't be that expensive. I mean, this part of the world is much cheaper, right? So you can just add, in case you're going for a meniscal repair, you can just add BMAC to it. I mean, it's not going to be a difficult part.
I'm jealous.
And what about, I just want to know the perspective from the US, especially you've been involved with the ANA and the ESM. What about osteoarthritis of the knee? What are the favorite injectable agents other than hyaluronic acid? What are these, whether people are using PRP, stem cells, I mean, BMAC? What is the
Right.
trend?
Yeah, it's a good
Early
question. I'm
osteoarthritis, early,
yeah,
early arthritis.
I'm a big believer in PRP and early arthritis. I think the data is impressive, especially leukocyte poor PRP. The difficult thing in the United States is it's so financially driven. In our institution, Jim Bradley, a legendary AOSM past president and my partner, he really pushed the hospital president to charge patients $260 for these PRP injections, which is cheaper, I think, than anyone else have really seen. Other people $500 or $1,000, $2,000 for PRP. So it's somewhat cost prohibitive. So it shouldn't be that expensive, but it's such a financially driven thing by a lot of non-operative doctors. They open these PRP or quote stem cell clinics, and I have people come in almost daily where they paid $10,000 or $12,000 to get stem cells, and they're given these IV vitamins and all these things, and it's just not right. I know the societies have pushed in the past to try to shut these quote stem cell clinics down, but it's difficult cost wise. But the data, in my opinion, shows that PRP is much more helpful than hyaluronic acid. It works for a higher percentage of people. We hope it lasts longer, a year versus 6 months, and it's your own stuff. So I'm a big PRP believer. I did it in my dad and my wife actually. I think that 3 injections a week apart with low leukocyte count is helpful. I'm really not a big fan of doing steroids in young people, but I think it really depends who you talk to. I think there's still the thought out there, but I bet over half of doctors or a lot of the arthroplasty surgeons that are not believers in PRP, they think it's a financially driven thing, which I think
That's
it is in some cases, unfortunately. But I think there's a huge role, just like you said, for early arthritis. But BMAC, we have an opportunity to do that, but I try not to push it just because it's so expensive. But I think ideally BMAC would be great. We're trying to get adipose an adipose portion set up in our institution, but with the FDA, it's somewhat difficult here. Like I said, we can't manipulate these cells. There is, just for a plug, at Case Western in the United States, they are doing a study where the FDA is allowing them to grow these stem cells, and some of my colleagues and friends are involved in that, like James Boos and Jake Kelsey, and their research is really promising. So I'm really looking forward to what they find, but I'd like to hear your perspective. I'm sure it's totally different. Like in the
Yeah,
military, they can do anything they
exactly.
want here.
Yeah, Justin, I think BMAC would have a role in AVN of the hip, especially if you're doing a co-decompression. Along with that, I think BMAC has reasonable role. What do you think about it?
Yeah, I think obviously without collapse, any kind of biology you can get there is helpful. I think some of those retrograde drilling devices and some of the new technology where you're able to kind of open a reamer and drill retrograde, I think that makes a lot of sense for sure.
Great. Justin, we are also joined by Loy. Loy, is he available? He was busy today. Loy, are you there?
Hello, guys. Sorry,
Hi,
still in
hi.
clinic.
Live from
Hi,
Dubai. Live from Dubai.
Hi from Dubai. Amazing lecture. Most really interesting lecture. Everyone wants to hear about it. Biological augmentation. Justin, one question maybe. Do you believe it's to reach a successful healing for the meniscal? Is it more biological augmentation or is it a technique dependent? What do you think?
Yeah, it's a good question. And I think the other good question I think you're alluding to is how do we even know what healing is? That's such a challenge. We don't even know when it's healed. Do we look at just patient reported outcomes? Repeat MRI. You don't know if it's healed. You don't know if those are sutures. How do you quantify the healing? I think makes all this more complicated, and also is why there are so few studies, and they're contradicting studies. So I personally think like the rotator cuff at this point, with different devices and techniques, if it's a well done technique, which I think you're right, it's not always done, but if you do a well done technique, I really think the biology is the issue. But I'm sure you guys see the same thing, that you see a large bucket handle tear and someone puts 3 sutures in it, which is much different than I prefer to treat it. I don't know what's right or wrong. Maybe putting more sutures in there and decreasing that normal meniscal mobility, which Freddie Fu taught us in the 90s, is not good. But I tend to put a whole lot of the sutures in there to compress it. But I think if you do a well done inside out or all inside technique and you're really stabilizing the meniscus, I think the biology is the issue. But certainly you got to start with the right technique. You're right.
That's thanks a lot. And the second question: how much does timing from injury influence your decision to repair? Is there any time
Yeah,
limit or cutoff?
that's a great question. We always wonder that. I always wonder too about whenever you do 1 versus 2 stage ACL reconstructions. If there's a 2 stage ACL and the tunnels are malpositioned or really enlarged, and you're bone grafting them, and you have a meniscus tear there. Some people advocate for fixing it right then, but then you're restricting their weight bearing, or you're worried they have no ACL. Is that meniscus going to heal? Do you wait for the second time? I've kind of switched to fix it the first time, but I do try to dissuade people. I just saw a few people this week actually that want to wait until after Christmas or at a more convenient time, and you're waiting 3 months to repair a significant meniscus tear with an ACL. I don't know the right answer. It'd be interesting to hear both of your thoughts as well, but there's no way that it's the same if you fix it, 3, 6 months later versus at the time. But I tend to maybe, I'm probably on the more aggressive side. Maybe it's too aggressive fixing these menisci, but I really have a hard time, especially with the lateral meniscus. We know, from the folks from HSS, just trimming out the lateral meniscus, those people are in a bad place if they're young. So I try to fix them all, whether it's right or wrong, I don't know. But, I don't know if there's a real cutoff time period, but, I worry months in waiting. But if you guys like to hear what you think too.
Yeah, I would do the same. That's right. There's no right or wrong answer for this question. I'm a bit aggressive with repairing, trying to repair, saving the meniscus. Whether it's a complex tear, whether it's a red white zone, all these parameters. I just try to fix the meniscus as much as I can. So tomorrow I do have 3 surgeries, 2 meniscal repair, ACL. So we'll try to preserve all these meniscus as much as I can. One of the questions that what if you want to choose one technique to augment your repair, what would be that technique? We would use PRP, would use notching, would use meniscal wrap. What do you think?
Yeah, I think it depends. Again, I'm so jealous of your guys' opportunity to use these other things like BMAC, but I would say if I had to pick one, I'd do PRP, but obviously there's some cost there. So I bone marrow vent everyone, but sometimes you put a bunch of passes through the bone marrow, and you wonder how much is really coming out of there. it seems like it's so patient dependent. So if I had to pick one, I would probably pick PRP, but I've never done meniscal wrapping, to be honest, due to the cost and opportunities. It's not available in our system, but I don't know if you guys have experienced any of those scaffolds, or I really am not doing fibrin clot, but what are your guys' thoughts?
No, I do actually fibrin clots. I do fibrin clots. Don't ask me about the results. We need a big RCT actually to get the results. Maybe the healing, but again, there's no different in the functional outcomes as you mentioned. I totally agree with that. Most easy. I do refreshing the rasping the meniscal edges. Good repair. I think good repair, good technique is the key. Then you can augment with some biology. The easiest one is PRP, and you some notching there. Meniscal, I don't have that much value with the meniscal wrap. I did a few of them. To be honest, is still I can't draw a conclusion regarding a meniscal wrap. Maybe it's a good technique. Over did one 2 years ago. Still, meniscal still healed. No complaints yet, but I think I need a larger number of this to draw a conclusion. Justin, that was an amazing talk. Thank you again.
Thank
Do
you,
you still have
Justin.
any questions, Peter?
Yeah, that's it. I think. Thank you, Justin, for yet another brilliant presentation, and have a great Sunday. And really look for more in the future.
Thank you. Appreciate the opportunity. You guys are awesome. And again, applaud you for doing this, taking the time out just for the good of the cause and education. It's amazing. So keep it up. Thank you.